Okay, well, thank you very much for the invitation. So the plan for today is to talk about approaches for sharing health information in a way that will not get you into trouble, but still maintain the value of that data. This is something we've been working on quite a bit over the last few years. We've been doing it on a number of projects, so I'll go through a few examples as well, or annotate what I'm talking about with a few examples. The slide deck I have has 12 sections, but I think we'll only have time for the first 6, and then we can stop and I'll answer questions, or if there are burning issues along the way, please interrupt, and I'll answer questions along the way as well. So we'll start off with some background. So this is our lab, and a lot of the things that I will be talking about, there are articles and materials on our website that discuss those issues. So if you want more details, you can always go there for those details. Plus, you may find it useful to subscribe to our mailing list. Every now and then we send out materials which are relevant to this topic. So I'll start off by talking about the benefits of sharing data. The biggest or the best example is sharing research data. This is an issue that has been looked at quite extensively over the last few years. There are many benefits to sharing research data. So this is the raw data. For articles that are published, the data is available. You can confirm the published results. There have been some incidents of research not being consistent with the original data. The availability of data for meta-analysis is also an important benefit. Organizations that have released data to a broader audience have benefited from getting feedback from the community about the quality of their data. Problems with the data collection methodology or inconsistency in their data, so the users provide that kind of feedback to help improve data quality. Of course, another benefit is the ability to reuse data without having to collect it again. So if one person collects data, the other researcher can reuse the same data without having to spend the money to collect similar data. And this is an issue also for publicly funded research or publicly funded work, where there are concerns about publicly funding different people to collect the same data. So if the data is available once for everybody to use, there's the cost savings there. And then minimize the need for the patients or the participants to provide data multiple times to answer similar questions. And of course, also data for instruction and education. If it's publicly available, then there'll be more data available for teaching and educational purposes. So there are many benefits to sharing research data, but data in general. Coupled with that, there's increased demand for health data. Researchers want more and more data to answer more difficult and bigger questions. There's more demand for data from public health to detect and to manage disease outbreaks, for example, especially when they're novel diseases. Being able to detect them early and respond quickly has been demonstrated is quite important. There are also commercial uses for advertising and marketing. So the advertising industry would say consumers benefit from having targeted advertising so that they don't get useless advertisements, and they need data to do that. And some people have phrased the stakes as certainly in the healthcare community, as it's matter of life and death. If we don't have data, we won't find cures or treatments or develop new drugs as quickly. And I've seen this statement made a number of times. It's a matter of life and death. We need data because it's a matter of life and death. So there is increased demand for health data. Okay, so you may already know this, so let me know and I'll skip if it's too obvious. But just a couple of terms that I will use. So I'll assume that there's, say, the health information custodian will collect data from individuals, or there's a disclosure from another custodian from one custodian to another, and then this is really these are really the two data flows that we are concerned with. So normally data is collected from patients for primary purposes, which are usually to provide care to the patients. But then you'll have secondary purposes where information is disclosed to, let's say, a researcher within or outside the institution, or to an agent who would be, for example, a subcontractor working for the custodian. So this is considered a use and this is considered a disclosure. In both of these cases, you have privacy issues that will come up when you share the data in these two ways. So in general, when we talk about health information, we have a number of types of data flows. We have mandatory disclosures. So a good example of that are the notifiable diseases or communicable diseases that hospitals and healthcare providers are mandated to report to public health agencies. I mean, there's a list of that, a federal list, but each province also maintains its own list of diseases that need to be reported. So these are mandatory disclosures, and that means that the healthcare provider must provide identifiable information to the public health agency or the medical officer of health. They're required to provide identifiable information, and it's not really optional that this information is not provided. In practice, of course, it's very different. We just finished a study looking at this is for family doctors, and their willingness to disclose data for public health purposes. And I mean, there's a lot of literature showing that even for mandatory reporting, there's a significant underreporting for a lot of diseases. And when we interviewed and spoke to the family physicians about why this is the case, privacy was one of the key issues that came up. So mandatory disclosures, yes. In practice, not always. You also have uses by an agent for secondary purposes. So for example, and this is happening often now as more IT is implemented in practices and in hospitals, you have all these subcontractors who have access to a lot of the databases in order to provide these services. Then you have permitted secondary disclosures. Again, I'll use public health as an example. Certainly in Ontario, public health is allowed, or information is allowed to be disclosed to public health. Identifiable information is allowed to be disclosed to public health without patient consent, with a very broad definition of what public health is. So this is permitted in Ontario and in a lot of other jurisdictions. However, the disclosures are discretionary. So the providers may decide not to disclose this data. And as I mentioned to you before, with the family doctors, for the non-reportable diseases where it is discretionary, they're quite reluctant to provide that information for public health purposes. So you have a class of information where this disclosure is permitted, but it's discretionary. It's similar for research purposes as well. And then you have other disclosures for marketing purposes, for secondary purposes, for example, marketing. And in those cases, you either obtain the patient consent or you have to de-identify or anonymize the information. So these are primary data flows. So here you have, at least under the current framework, you have really two options: either obtain patient consent or anonymize the information. These are for the disclosures for other disclosures for secondary purposes. Here, in practice, the healthcare providers often, they'll either ask that consent be obtained. In many cases, obtaining consent from the patients is not easy. There are practical constraints. I'll talk a little bit about that later on. Or they require that the data be anonymized. Here, when the information is used by an agent, in this case, identifiable information can be used. And I'll make the case that even in that case, it's advantageous to anonymize or de-identify the information from a risk management perspective. Okay, so what I will cover now is I'll make the case for de-identifying the data as a means of, or anonymization of data as a means to facilitate all of these data flows, either because it's the only way you're going to get the data or be able to share the data, or because it's prudent best practice to manage the risk when data is disclosed. And then after describing or making the case for the identification, I will then, if you go back to the overall schedule here, and then I'll talk a little bit more about identifiability, how do you actually measure identifiability, and some practical issues around implementation, like, for example, defining thresholds. Okay, so the case for de-identifying or anonymizing health information. These are the main points, and I'll go through them one by one later on. But in practice, it's often not possible to obtain consent. So wherever consent is an option for disclosing data, in many situations, especially when you're releasing data or disclosing data for secondary purposes, it's not practical to obtain consent. Even if it is practical to obtain consent, there are disadvantages to obtaining consent. And there's an overwhelming amount of evidence supporting that, a key one being bias. Consenters and non-consenters differ on important characteristics, and therefore you will tend to get a biased sample if you ask for consent. I mean, it doesn't mean it's terrible, it just means you have a biased data set, and that raises some additional issues. In practice, custodians are reluctant to disclose information even if that disclosure is permitted. So as I mentioned to you, the family physicians were reluctant to disclose identifiable information. They wanted the information to be anonymized or de-identified before it's disclosed for public health purposes. In most privacy laws, you have limiting principles which require that the minimal amount of information is disclosed. So this is the case here in Ontario. It's the case in the US under HIPAA, when HIPAA talks about minimal necessary information. So this is relatively common. The other issues, of course, of data breaches are common. So from a risk management perspective, it is better to have anonymous information. You also have a number of unplanned and unexpected disclosures that are happening as we speak. So a good example are the electronic medical record vendors. So these are the companies that are installing software to manage health information. They are anonymizing and selling that data. Whether the patients know or not is a different question. In most cases, they don't know. But there are a lot of disclosures that are happening that are not bubbling to the surface from a public knowledge perspective. There's the whole issue of public trust. And then, again, the public has made the point that they're more comfortable if the data is disclosed, if it is anonymized or de-identified. And other methods for sharing data, apart from anonymization or de-identification, have a number of disadvantages to them. So I'll cover some of these points. And in terms of obtaining consent, sometimes it's not possible or practical to obtain consent. So sometimes making contact with a patient may reveal their condition. For example, let's say it's a child and who had a condition when they were young, and then now they're over 18, they're an adult, and you want to recontact them to obtain consent to use their data for some other purpose. And as an adult, maybe their adult family doesn't know that they had this condition when they were younger. So the process itself may reveal the condition to others. Sometimes the size of the population that you want to obtain consent from is too large and it's just not practical. For these population-based studies, you may have hundreds of thousands of individuals, and obtaining consent from such a large number of people may not be practical, or it's often not practical. Sometimes patients have relocated or died, and it's very expensive to track them down. If you have a data set with a large number of patients, and it's been many years since the data was collected, there may be a lack of existing relationship with the patients, so it's difficult to justify going back and contacting them. There's a risk of inflicting psychological or social harm when you contact these individuals about maybe a traumatic experience that they had experienced at the time when the data was collected. Some have suggested you can use advertisements or other public notices to inform the public that you're using the data for these secondary purposes, and that also sometimes may be difficult. So there are practical constraints to actually going out and obtaining consent from patients after you've collected the data from them in order to use it for secondary purpose. And I mean, here we're talking about data that was collected originally for care, and now you have it and you want to use it for another purpose. In terms of the impact of obtaining consent, so we did a number of systematic reviews of the evidence looking at the difference between consenters and non-consenters. So we did it in the context of clinical trials and in the context of observational studies, and the evidence is overwhelming. So in the context of clinical trials, we did a systematic review of systematic reviews, because there's been more than a dozen systematic reviews on this already done. And there's clear evidence that in the context of trials, that consenters, so people participating in trials, tend to be different from non-consenters on a number of variables. And then the same story was found for observational studies. So this is when you may not necessarily intervene, give the patient a drug, you're just using their data for some other purpose. When people went back and asked the patients for the consent to use their data for this other purpose, again, the same thing happened. And the differences pertain to age, sex, race, marital status, educational level, socioeconomic status, health status, mortality, lifestyle factors, level of functioning, actually, and a few others, about a dozen variables where there's a difference between consenters and non-consenters. So when you see consent, for example, older people may be more likely to consent than younger people, males may be more likely to consent than females, or vice versa, depending. It depends on the treatment or the population that you're talking about. But there's often a bias that those who consent and those who don't consent are different from each other. So, for example, let's say if race or educational level were important confounders in your study, and you obtained a biased sample because of those who consented, then that may have an impact on the results of your analysis. So it's important to remember this, that there could be a potential for bias along these kind of basic participant characteristics if you seek consent, by asking individuals to consent. It's the same thing for opt-in and opt-out consent as well. So those who opt out tend to be different than those who don't opt out, and those who opt in tend to be different than those who don't opt in. The other factor, of course, is the consent rate. So it varies from, say, 16 to 93% in our review, which means that in some cases very few people consent, which means you have to ask a large number of people to you have to ask a large number of people if you want to get a data set that is large enough, basically. So that has a direct impact on time and cost for doing any analysis. But I think time and cost is not really a strong excuse, because someone can say, well, you just need more money to do these kinds of studies and allocate more time. I think the big issue here from a practical perspective would be the bias that consent really introduces a lot of bias. So from that perspective, from practicality, where it's not practical to obtain consent, and because of the bias introduced due to consent, for many of the data flows that I mentioned earlier on, de-identification or anonymization is the only other way that the data can be shared or disclosed for secondary purposes. And then the other thing, of course, why it's anonymization and de-identification is important is this issue of discretionary disclosures, the fact that healthcare providers don't want to disclose data. So we've been involved in a number of public health related projects, and the providers have been reluctant to disclose data unless a strong case can be made that it's anonymous data. Even though they're allowed, they're permitted to disclose identifiable health information, they do not want to do it. They're very uncomfortable, and part of the reason is they don't think the patients would be very happy if they found out that their provider is disclosing identifiable health information. This was the case with the family physicians, where they were concerned about the patient-physician relationship and how it would be impacted if the patients found out that their doctor was giving out their identifiable health information to some other party without their knowledge. So providers generally tend to be very reluctant to disclose identifiable information, even if they're permitted. And often they will require the data be de-identified before it's disclosed in order to give them that additional level of comfort. So discretionary disclosures are good, but in practice, it has to be de-identified anyway. Of course, the other point is that limiting principles, for example, in PHIPAA, well, this is essentially the definition. You will not collect, use, or disclose personal health information if other information will serve the purpose. This is usually interpreted to mean you reduce the number of variables that you use to only the variables that are needed for whatever the purpose is. And if you don't need identifiable information, then you should de-identify the information before you disclose it or use it for some, disclose it for some other purpose. Breaches. So this has also become a very big issue about data sharing. When we speak to providers, this comes up is they read and see in the newspapers and hear stories about all these records that are being lost or stolen all the time, and so they're concerned that if they provide their patient's information to some other party, will they really take care of it and be as protective of it as they should be? So the breach stories that are coming out have increased the level of concern about data sharing. And I'll talk a little bit more about breaches and why we should be concerned about it. But the main point is that de-identification provides one way to manage the risks from breaches. So if there's a breach and the data set is de-identified, then the risk to the patients is minimal because it's de-identified information. Then there's a whole issue of trust, and I'll talk extensively about trust as well. We do know that patients change their behavior if they have concerns about privacy, and there's accumulating evidence to show this. And behavior change means not seeking care, lying, and so on. And of course, this has a negative impact on the well-being of the patients, but also has a negative impact on the quality of the data. If you have data where 20% of the patients have been lying, for example, you're not going to have very good data. So it has an impact on quality of data as well as the well-being of the patients. If you're using the data for research or some other purpose. Okay, so now I'll just dig a little bit deeper into breaches. So when you talk about breaches, this is a question I often get: is so what? What's the harm? Okay, harm is complicated, and it's. I mean, in court cases, at least in the U.S., the judges have generally tended to say if there's no evidence of direct harm to the patients, then there is, due to a breach, then there's no case. Probabilistic harm is not considered harm. So if there's a probability of 90% that identity theft will occur, that's not considered as convincing enough. Identity theft would have had to have occurred with the breach data, and a link to the actual breach as the cause of that has to be demonstrated in order to make a case that harm has occurred. So I'm talking here about harm in a kind of a conceptual sense. So for custodians, for data custodians, whenever there's a breach, you have reputational damage to the organization, and in the U.S. there are possibly penalties. So in the U.S. when breaches occur, either state attorneys general or the Department of Health and Human Services has penalized the organizations for these breaches. And then of course there are examples of extortion attempts as well, which again have additional reputational plus financial consequences. From the patient perspective, a lot of medical records do have financial information or information that can be useful for financial fraud. This is more in the U.S., but it's the case in Canada as well, where credit card information may be there, or mother's maiden name information may be in the medical records. So the medical record may contain financial information, which can be used for financial fraud. Now, just because it's a medical record doesn't make it immune from being used in financial fraud. Then, of course, there are cases of medical identity theft, and then there's the issue of trust, and even if there's no harm per se, because people change their behavior, they may actually cause harm to themselves through their behavior changes. And then, of course, providers, there's the issue of trust as well. For example, the family doctors, when they have concern about the patient-physician relationship, if this trust is damaged, then it has some other consequences in terms of, again, patients changing their behaviors. but also providers being less reluctant to disclose information. So breaches have a broad set of consequences. So in terms of extortion, I mean, this is a good example. There are two good examples of extortion that have come out publicly. This was in 2008. Express Scripts is a company in the US. They also do business in Canada. So they do insurance claims processing. So the story there is they had their software quality assurance or testing group, basically, quality control group, was using production data to test the software. So their production data was well secured, but their testing group had lousy security practices. So, but since the testing group had the same data as the real databases that were used in the business of the company, somebody broke in and stole data. They sent them a letter with information on 75 clients that included date of birth, social security numbers, and some prescriptions. And whoever it was wanted money in exchange for not disclosing the data further. So Express Scripts, of course, notified the FBI, and they started an investigation. Later, whoever did this sent the information to the 75 clients, telling them, I have your data, to put additional pressure on Express Scripts. We don't know the actual ransom amount or the amount that the extortionist had requested, but apparently it's in the millions. And later on, some of those 75 clients were initiating lawsuits against Express Scripts for losing their data. It turned out later on, of course, that the actual number of people who had their data lost through this break-in and theft of the database was about 700,000. So the case is still ongoing. I don't know if they found out who it is or whether they paid the money, but this is an example of extortion. Another example is this is the Virginia Prescription Monitoring Program, which was a website that was used to provide prescription drug information, mainly to track prescription drug abuse within Virginia. And someone broke into it and defaced the website, the main page, and this was the ransom note on the main page of the website. And I have your shit in my possession right now are 8,257,000 patient records and a total of 35 million prescriptions and so on. And essentially ransom note posted on the main page of the website. And this particular extortionist wanted $10 million. So again, you know, maybe they called the person before they paid, or maybe they paid. It's not clear. But the point is that extortion can be potentially good business in the sense that if you can get access to this data, it's very sensitive information. It's very bad publicity for the custodians, and I mean, in some cases, they may pay the amount to make it go away. So that's one way that the breaches can be damaging to individuals as well as the organizations. One other question that I often get is, well, you know, this is theoretical. It doesn't actually happen here. So, I mean, especially those who work at hospitals or deal with hospitals, you know, do you know of any cases where computer equipment was stolen from a hospital? Yeah, I mean, it's very common. Sorry, do you have a question or? Oh yeah, okay. So a couple of folks, I know of many cases where this has happened. Some of them get reported, some of them don't. Does this equipment contain personal health information? Well, most of the time, yes. Memory sticks being lost or stolen. Laptops. I'll show you now some data on the on breaches. Most breaches are laptop breaches. The most common way that information is lost is laptop theft or lost. And of course, the whole issue of sending email containing personal health information to your Hotmail or Gmail account. Many people do this. It's to get around practical constraints. People email data to their Gmail account so they can access it from home and work from home. The problem is that, I mean, people trade in Gmail account information. There are websites you can go where you can buy, you know, 30,000, 50,000 Gmail credentials. So you can go in. So not a very safe place to keep your patient's personal health information. And of course, the whole issue of sharing passwords as well, and the strength of those passwords. So we just did well, not just, we completed a study some time ago looking at passwords that are used to protect files that contain personal health information that are exchanged by email in the context of clinical trials, and we were able to crack almost all of the passwords using a $50 commercial password recovery tool. So let's say you have a zip file and you password protect it and then send the zip file off to somebody else. And the zip file contains personal health information, and whether it's password, the password protection includes encryption or not is irrelevant if you can crack the password. And so most of these passwords are so weak that it was not actually difficult to recover them with $50 worth of investment and a few computers running for a few days. And of course, there are also known data leaks that are happening, which don't get reported. So things like personal health information on second-hand computers. We did a study on that some years ago. We rebought second-hand computers and were able to recover lots of PHI from quite a lot of them. Leaks of PHI through peer-to-peer file sharing networks. Percentage-wise, it's small, but numbers-wise could be large. PowerPoint files on the internet. So download a few PowerPoint files, whatever you see a graph, double-click on it. It'll open the Excel spreadsheet that was the basis for this graph, and you'll be surprised what people had in those Excel spreadsheets. They're unknowingly paste graphs from Excel spreadsheets into PowerPoint files, and sometimes the raw data is there with PHI embedded in Excel as well. Yes?
The example I was going to add was Halifax 9798, one of the hospitals was offloading their own hardware, and before it went in, we sold this application information, so just wondering how it was.
Yeah. So. Yeah, I mean, so the whole issue of discarding equipment is big. More recently, you saw on the news the whole issue of photocopiers, and photocopiers are computers with hard disks that contain images of all the things that you photocopied. So I mean, these are other ways that data can leak. I'll just show you a. So this is we collected the. There are some organizations that collect breach information from state attorneys general, from newspapers, and so on. So this is one of those sites. We collected the data from 2005 to December of 2009. So over that period, and in general, we can see that, and out of all the total breaches, there were. This is only counted in the U.S. 174 breaches that were collected in this registry, which represent about 12% of all breaches were medical. So they involved healthcare organizations. And in terms of the number of records, about 5% of all the records that were involved in breaches were medical records. The number of breaches that are reported do not necessarily reflect all the breaches that occurred. We just did a study where we tried to estimate the total number of breaches that were notified. You have breach notification laws in most states and in some parts of Canada. So when we looked at the U.S. only to estimate the total number of breaches that were estimate them, number of breaches that were notified, not necessarily in any one of those breach notification lists. It's about a few hundred a year. Breaches that involve medical records. It varies by year. There's been a drop-off over the last year in the number of breaches that are being notified, and the only plausible explanation for that is people are not notifying the breaches that are occurring, which is a whole different story. In terms of method, a couple of interesting observations. One is that so here you have insiders. About 14% are insider accidental and 11% insider malicious. So roughly here you have, say, 26% of all breaches are from insiders. This means people inside the organization, which brings us to the whole issue of agents. So we said that agents who are insiders essentially or subcontractors to the custodian The reason you want to put some restrictions on their access to data as well is because 25%, according to this data, of breaches are caused by or due to insiders. So these are individuals in the organization either sending data to the wrong place or if it's malicious, actually stealing it and trying to blackmail the organization or trying to sell the data. I mean, there are stories of this happening. So even agents or internal or, individuals, it's as a prudent risk management exercise, it'd be good to only give them the information that they need for their work, which may include anonymization of that information. The other thing that may be interesting to note is, let me see here. Well, I mean, if we look at loss, you see that laptop loss here constitutes about 17% of all the lost items, and drives constitute another 22%. So we put laptops and drives together in terms of loss. They constitute a large percentage of the breaches that are reported. These charts are on our website, so you can play around with them and look at them to see what the trends are. In terms of insiders, more recent data that was came out this year shows that the percentage of insiders is closer to 50% rather than the 25% that I showed you. So to the extent that, that's each one of these studies, of course, is based on a different data set. So, but it's high. I guess the point is different data sets show between quarter to a half of breaches are due to insiders. So have to be cautious about giving data to folks within the organization as well. Okay. In terms of identity theft, I mean, this is a Canadian example. So this gentleman collected information about dead children who died in a different province 20 or 30 years before, and then reissued, so a different province from when they were born, and then went and reissued birth certificates for them, was able to obtain birth certificates for them because the province where they were born did not know that they had died. And then with that piece of foundation identity was able to create additional pieces of identity, passports, social insurance cards, etc., and then created these identity packages and was selling them for around $37,000 each. And when he was caught accidentally by the Edmonton police, they found boxes of identity packages that were for sale. And when they traced them, the people he had sold it to, one was a drug smuggler, was caught with one of these identities. Another one was an American citizen who was getting unauthorized medical care in Canada. He was caught at the airport as he was trying to leave. So there are examples of people committing medical identity theft using stolen identities. This is not theoretical. And these are the kinds of things that, law enforcement doesn't really talk about very much, but the stuff that does come out in the public domain does indicate that it can happen. We just don't know how often it happens. So, okay. The other important factor to consider is trust. Oops. Okay. So, again, when disclosing data that hasn't been anonymized, or where the patients have concerns over privacy, there's evidence that patients change their behavior. So in a number of surveys done over time in multiple different groups of people, between 15 and 17% of US adults and 11 to 13% of Canadian adults admit to changing their behavior in some way because of privacy concerns, and changing their behavior with their physician, so in the context of receiving care. And vulnerable populations are the most likely to exhibit those kind of behavior changes. Adolescents, people with HIV or high risk of HIV, those undergo genetic testing, mental health patients, and battered women. And the kind of behavior changes include going to another doctor, so you have multiple providers rather than one provider, which is generally not a good thing. And now that we don't have electronic medical records exchanging data, that can be one way to segment your information. So no single provider knows everything. Paying out of pocket when insured to avoid disclosure so that information doesn't go to your insurer. Insurer doesn't have the details. Not seeking care to avoid disclosure. Giving inaccurate information or incomplete information in medical history, so essentially lying to the provider. asking the provider not to record any health problems so that the record doesn't include that. You have to also remember that, for example, when the insurance company asks for, when you consent to your medical record being provided in the context of applying for insurance, when the request goes to your doctor, the doctor doesn't select the pages that apply. They just send the whole thing. Some do, but many don't. And this is with your consent. So anything that goes into your medical record is potentially available to, let's say, insurance companies when you apply for, say, disability insurance or life insurance. So some people ask not to record health information. Many physicians admit to not recording information because the patient asked them not to record it, was sensitive, perceived as sensitive, didn't want to include it in the record. And this is another example, which was in the New York Times in January of last year. So this is a story about women of Dominican origin living in New York, asking their pharmacists for an ulcer drug, which is also known to induce abortions. And the reason they do this is they don't seek care because they don't want anybody to know that they're trying to get an abortion. So they get this drug, which is known to have this side effect. And sometimes it works, sometimes it doesn't work with some terrible consequences. And it's largely driven by privacy concerns. They don't want a record of this, of them having an abortion. So again, these are not theoretical risks. These things happen. People do change their behavior when they have concerns about privacy. The other issue about trust, of course, is, and it's very important as we kind of move into this age where data about individuals is being collected in databases, large databases, and the potential for this data sharing to occur, is that trust is very easy to obtain. It's hard to obtain, but very easy to lose. This has been demonstrated in the context of genetically modified food, in the context of nuclear power, and other contexts that people tend to lose trust in organizations very quickly. Some of the reasons, the negative events carry more weight than positive events. So people hear a bad story, for example, a data breach about a provider, that carries a lot more weight than if they hear that this organization did something good. Generally, people try to avoid loss, so they weight negative information more greatly in an effort to avoid loss. Sources of negative information appear to be more credible than sources of positive information. Positive information seems to be kind of biased or self-serving. People tend to interpret information according to their current belief. So if they have negative beliefs, some negative belief about an organization prior to hearing a negative information, get information about a negative event, it just reinforces that. And positive information will have little impact. So if people start developing a negative attitude or negative perception of an organization, it impacts their trust, and it's kind of self-reinforcing as any negative information comes. It reinforces that positive little effect. And of course, people have positive beliefs about an organization, and when they hear something negative about them, they feel betrayed. So it has again a disproportionate effect on their trust of that organization. So public trust is very important, because if the public loses trust in that their data custodians are not handling the data well or in a responsible manner, they will start see people changing their behavior and so on. And again, one way that in surveys of the public, one way that they feel comfortable with sharing their health information is if this information is anonymized. And one other thing I should mention is it's important to notify. The public needs to be aware of what's going on. I think this is a problem that we have today, is that there's a lot of stuff going on and the public has no idea that this stuff is going on. So it's really important that the public is aware so they're not surprised when they find out that some kind of data sharing is occurring, because when they're surprised, you start having all of these negative effects. Just some recent surveys. The question was, how safe and secure is the health information which exists about you? So this was a survey conducted by the Federal Privacy Commissioner, Health Canada, and InfoA. So 39% had positive opinions, and the rest not so positive opinions.
What's the question?
In your opinion, how safe and secure is the health information which exists about you? I'm sorry, you can't see it. It's down here. This there's a 7-point scale, and the people who responded from 5 to 7 are tabulated. It was 39% overall responded in score from 5 to 7. So, I mean, 39% is not high. It's not low, it's not terrible, but you know, when less than half of the population feels safe about how the health information, how safe and secure their health information is, it's not very high, and you know, you don't want to lose more than that. This is another survey, kind of similar results. This was an older one, and this was one that was, I believe, commissioned by Health Canada. I really worry that my personal health information might be used for other purposes in the future which have little to do with my health. 50% agreed to that statement. To give you a sense that the public has some concerns because of all the things we know about changes in behavior and trust. We really have to be aware of this and be very careful about this so that it doesn't move any further south than where it is right now, because that can have undesirable consequences. So for all of these reasons, then, under the existing frameworks anyway, one way to be able to share information in a way that the public is more comfortable with it, and that avoids the problems with consent, is to anonymize and de-identify the information. So now I'll start talking a little bit about the identifiability issue. The other point, of course, is, you know, but there are other ways to share information. So there are other ways, like, for example, creating these safe havens where, like the research data center that Statistics Canada has created, it's right here, the one in Ottawa, in the library, where specific people are screened and they can have access to information within this environment that's secure and no data is allowed to go out and so on. And then another option that's sometimes used is to provide remote access to data. So in the case of remote access, I mean, the number of difficulties there with remote access is that if you've never been the victim of a phishing attack, let me tell you what happens. You receive an email from a trusted person within your organization telling you your password has expired, it's really important, or we had it, no, this is a good one. The email from a trusted person within your organization says, we've just had a security breach, everybody has to change their passwords immediately in order to avoid any more problems. And then there's a link to a website that you click on to enter your previous password and then the new password. And you click on that, you go to a website that looks exactly like the website of your organization, and you're panicking and you say, I have to do this very quickly. So you enter your password and submit, and you feel happy, you've done the right thing. And then a few days later you find out that this was a scam, right? There was no breach and someone just got your password. And during that interval from the time you provided the information to the time that you discover this, whoever did this will have access to your password. So this is a problem with remote access, is that whoever has the password to the data, to the remote access, can access all the data. And it's not difficult to do this, okay? This is a very simple attack to launch to get passwords. You just need to know who the trusted person is within the organization. You need to mimic the public website of the organization, and you have to phrase the email, in a convincing way. So that's really the big problem with remote access, is that anybody who has the password can go in and access all the identifiable information for a certain period of time, and that would be considered a serious breach. The problem with on-site access is just the fact that it has to be on-site, and people who are not close proximity to where this secure site is will not be able to access the data. And of course, there's also the whole issue of the screening process, and like the StatsCan RDC, there is a screening process that may take a few weeks, so it just adds some additional time to the process. But really, the big disadvantage is you have to go there in order to access the data. So these are disadvantages of these other modes of sharing data, providing data. The other way, of course, that some people have advocated is to put data on the web, make data publicly available. So, I mean, making data publicly available is the extreme example of data sharing. And if you can appropriately de-identify that data and anonymize it, then that would be a good thing. For example, in the context of clinical trials, there are some people who are, because of the problems with pharmaceutical companies not being completely honest with what's going on in their clinical trials in terms of what studies have been done, what the data said, and the adverse events that were not reported. There are some people who are advocating making all data from clinical trials publicly available as well. And whether that flies or not, we shall see. But the idea is to make that all the information available. And I see a trend of a lot of organizations, especially those who are funded through public money, wanting to make as much data as publicly available as possible in order to facilitate, transparency, but as well as reuse. Okay, so now we'll talk about identifiability. And so how do you anonymize data so that you can share it, basically? So here are some definitions from various provinces. So in Ontario, identifying information means information that identifies an individual or for which it is reasonably foreseeable in the circumstances that it could be utilized either alone or with other information to identify an individual. Most of the definitions for the other provinces are the same, similar kind of wording. There's the reasonableness standard that's used in most cases. The difficulty is to operationalize this definition. How do you apply this in practice? If you're a privacy officer, if you're a researcher, if you're a data custodian, if you're a chief privacy officer at a hospital, how do you operationalize this definition so that you can share data, make data available, but make sure that it's not individual identifying or it's not identifying information? So in general, identifiability is on a spectrum. We can scale it to be between 0 and 1. So 0 means the information is not identifiable, and 1 means information is identifiable. 0 basically means you don't release any data, because if you release any data or disclose any data, there is some risk of re-identification. Identifiability is not 0. I mean, as a naive example, if I give you some data, if you select a name from the phone book and say record number 7 is that person, the probability of that being correct is not 0. It's low, it's very low, but it's still not 0. So identifiability is on a spectrum. And so in order to operationalize these definitions really make a distinction between identifiable and unidentifiable. It's a binary distinction. So we need to define a threshold. We need to be able to say, well, at some point along the spectrum, identifiability is above that point, above that threshold, identifiability is too high, and therefore it's personal information. And as soon as you're below that threshold, then it's low, and it's not personal information, right? So then, that's kind of a pragmatic way to move forward in terms of having a repeatable, consistent way of looking at identifiability. So we really need 3 things, or 2 things, depending on how you describe them, I guess. You have to be able to quantify identifiability along some kind of spectrum. If you're going to be able to define a threshold and say what's above is too high, what's below is acceptable, you need to be able to quantify and measure identifiability somehow. And then, of course, you need to be able to define a threshold or agree on a threshold that is acceptable. Right? At what point is the risk or is identifiability too high for you so that it becomes personal information? So now I'll talk a little bit about those 2 things and how you can operationalize these in practice. So this is a model that I found very useful for describing, I don't know if you can see it, it's kind of, I'll walk you through it, for describing identifiability. So it's a 5-level model. Level 1 essentially means readily identifiable information, and level 5 means aggregate data. The definition of aggregate data is often very fuzzy. A lot of organizations, well, there's a lot of variability in the definition of aggregate data, but basically it's kind of tabular data that may contain counts or means, but from which it's not possible to identify individuals. As you go up in this, as data moves from level 1 to level 5, it becomes more difficult and more expensive and requires more skill to re-identify. So even level 5 data, it's not impossible to re-identify. It just requires an incredible amount of effort and skills in order to re-identify individuals in aggregate data. And of course, as you go down, the risk of re-identification is higher. And this is supposed to be a descriptive scale, so this is what I see happening today. So the next level of the identification or reduced identifiability is what we call masked data. So if you can think of a data set that may contain names and addresses and social insurance numbers and health insurance numbers and so on, and as well as some clinical information, masking essentially involves removing all the obvious or direct identifiers, removing all the names and addresses, social insurance numbers, medical record numbers, credit card numbers, health insurance numbers, etc. Direct identifying variables are somehow masked. So they're masked either by removing them from the data set or by encrypting them or by replacing them with a unique key. But essentially you deal with direct identifying variables only. And there are two kinds of masking. There's reversible and irreversible masking. Sometimes you want reversible masking, so if you replace all your direct identifiers with a key, let's say in a public health example, if you disclose data with a key and you want at some point to go back and contact the patient or to do contact tracing or to find out where they've traveled in order to initiate an investigation, then you go back to the hospital, say, I have data with that key, can you tell me who that person is, because we really need to contact them. So in that case, you have reversibly masked data where there's a key that can be used to re-identify individuals, and there are various ways to handle that key. And then irreversible is where it's not possible to figure out the individual from the key. So this is great. Masking is good. The next level are organizations who release or disclose what I call exposed data. The reason it's exposed data is they do something to the data beyond masking, and they think they've de-identified it or anonymized it, but they haven't. And this also happens quite often. And I'll show you some examples of that in a minute. And the reason it's exposed is because the organization is exposed. The organization has disclosed data that they think is anonymous. They think it's not possible to re-identify any of the patients, but because they haven't measured the risk properly, they cannot say so with certainty that that's the case. And in many situations, when you don't measure the risk, you really are, cases that I've seen, the risk remains quite high. Managed data is when you're actually able to measure the risk of re-identification. You're able to measure identifiability. And as soon as you're able to measure identifiability, then you can decide whether it's above or below the threshold. And if it's below the threshold, then this is not personal information. If it's below the it's above the threshold, then it's considered personal information. And this is the only way you can actually manage the risk. If you can measure your identifiability, then you would know whether this is personal or not personal, right? So this is what I will talk about, is how do you get to level 4. So masking is very common practice, so I'll talk a little bit about that. So it really just involves removing names and addresses and other direct identifiers. The problem is with masking, it's quite easy to re-identify individuals even after you've masked information. And you can do that from the other data that's left, or the other information that's left in the data. I'll just give you an example to illustrate what I mean. Imagine a data set here where you have name and gender, and you have, this is a people who died from cancer, let's say, year of death and some test results that were done on them, and various other clinical information. So with masking, you would basically convert it to this kind of data, where you would replace the name with some unique key, with some pseudonym, and then you would retain the other pieces of information. But essentially, with masking, is you only deal with these fields here in order to mask the identity of the person. But you keep other information like the gender, year of death in the data set. The problem is there are known examples where individuals can be re-identified from masked data set. So these are 6. We did a review of re-identification attacks that have occurred, publicly known, and there are 13 re-identification attacks that are publicly known. And when we looked at all of them, there was only one exception. 12 of them were masked data, and the last one, the 13th one, was done in the context of a national statistical agency doing an exercise. Has other issues with it, but the main conclusion is that all the known re-identification attacks that have occurred were launched or done on masked data sets, where level 2 data basically. And it is not surprising that in these cases it was possible to re-identify. So masking is not enough, basically. So I'll give you some examples. I'll talk about the two Canadian examples here. So this happened at CHEO at the hospital, and what happened, we were approached by a company that wanted the prescription records of the hospital. They were creating a national pediatric hospital prescription database. And these data brokers, they will combine this data, analyze it, and sell it to the pharmaceutical industry, or sell the reports from that data to the pharmaceutical industry. And then so they came to the hospital and said, we want to collect this data about your patients. Here are the fields we want, and this is all the identified information. So the chief privacy officer asked me whether it was really the identified information. He gave us the data set and said, this is the information they want. So I asked people in the office if they knew anybody who was admitted to the hospital during that period. So a colleague said, yes, my neighbor, less than 1 year old girl. Here's her postal code. I know her postal code. She's my neighbor. And it was in January of that year that she came in. So we looked at the database and only one record matched. So we were able to figure out what was her record. We knew exactly when she came in, when she came out, all the drugs she took, what she came in for. We called the mother just to confirm, is this your daughter? Did she go in on that date, etc. And this is all within 5 minutes. And then we went back to the hospital and said, look, patient number 7 is so-and-so. It wasn't very difficult. And this was kind of the classic nosy neighbor attack. So this was a neighbor. He just knew that the girl went to hospital, and he knew the postal code, and he knew roughly when. He didn't know exactly when. He knew roughly when. He knew roughly her age. And the fields that were requested included, admission date, postal code information, age information, and so on. So it was not that difficult to do a match. So we ended up, I'm just going to skip these. We ended up negotiating with the organization to properly de-identify the data and only disclose properly de-identified data to them. So the initial request for data, despite their very strong representation that it was de-identified data, it wasn't. And this is what I mean by a lot of organizations think they have, or disclosing or requesting de-identified data, but without actually measuring it, they may be exposing themselves. This is an example between the CBC and Health Canada. And so, I'm telling you the story based on discussions with people involved in the case and court documents, but basically the CBC asked for the adverse drug event database from Health Canada some years ago in order to investigate a drug. Health Canada gave them the data. It was an acne drug. They found a 26-year-old girl in Ontario who had died while she was taking the drug. They matched that location and death and age information with the publicly available obituaries. They found 4 families who matched, contacted the 4 families, zeroed in on the correct family, and did a story on the Diane 35 drug, which was eventually pulled off the market by Health Canada. So this is a classic example of using publicly available sources of information in order to re-identify an individual. And then, of course, CBC went back asking for more data, and Health Canada refused to give them the same data. Then this case went to federal court, and the ruling was against the CBC, that Health Canada did not have to disclose it was the province field that they were fighting about. So, but the original story about the CBC and the Diane 35 was essentially a re-identification attack. So I think these are the only 2 Canadian examples. Most of the examples of re-identification attacks occurred in the US. There were some in Germany, some in the UK, but the vast majority of them were in the US. So it's not possible, it's not difficult to re-identify individuals if the data is only masked. And in both of these cases, the data was not de-identified properly. They kept, the most critical pieces of information are location information, date of birth, age information, any date information, any geographic information. These are the 2 key pieces of information that make it easy to re-identify individuals. Okay, so one way to measure identifiability is to look at uniqueness, and there are really kind of 2 ways to look at uniqueness: uniqueness in the data or uniqueness in the population. Uniqueness means that an individual is unique in your data set. So on the variables that you're interested in, the variables that can be used for re-identification, we call them quasi-identifiers. the individual is unique on those. It means they're the only person with those values on those variables. For example, if the values are date of birth and postal code, then if you're the only person who was born on that day and who lives on that in that postal code in the database, then you're unique in that database. Okay. So various studies have been done in the U.S. One was done showing that 87% of the U.S. population is unique on the date of birth, zip code, and gender. So if I know your birth date, zip code, and gender, then I can, good chance, I mean, it varies depending on the part of the country, but there's a good chance that I'll know who you are just from these three pieces of information, because these are quite close to being a unique identifier. A subsequent study showed that only 63% of the U.S. population is unique on these three variables. The issue with uniqueness is that it makes it easier to re-identify individuals. So I'll show you, I'll walk through an example. This is, I think, hopefully you can see some part of it. So let's say you have this data set. This is a data set with 14 records in it, and you have these quasi-identifiers, gender, and the year of birth of the patient, and then some test result or some clinical information here. So 9 out of these 14 individuals are unique. Let's say that I'm a neighbor of one of these people, and I know that that person is in the database. I know that my neighbor is here, and I know their year of birth, and I know their gender. Then if my neighbor is one of those unique people, I would re-identify them right away, right? So that's one reason why uniqueness is a problem, is that if you have unique records in a database and an adversary knows that certain person is in that database, then the unique people in that database are very easy to re-identify. An adversary can know that someone is in a database by can know that a person is in the database if the database is the whole population. So if everybody in the let's say all cancer patients are in the database, and the neighbor knows that my neighbor has had a cancer, then he'll know that that person is in the database, and if they're unique, then they will be able to re-identify them. Let me just show you something which may be of interest to you quickly, since I'm running out of time. So this is based on a study we did in Montreal. So we got data on about 1 million Montrealers over 11 years from the provincial health insurer in order to look at uniqueness in the population. I'm comfortable generalizing this to other urban areas in Canada. So we have here if you look at the date of birth and gender, so we have here on the x-axis is the postal code. So you have one character all the way up to 6 characters of the postal code, and this is essentially uniqueness, the percentage of the population that is unique. And this is for 1 year only. So if we have 6-character postal code and the full date of birth, about 97 or almost 98% of the urban population, and as I said, I'll generalize this to the country, is unique. So essentially, a full date of birth, postal code, and gender are a unique identifier for urban Canadians. For rural Canadians, the number is smaller. It's still quite high. The reason the uniqueness is much higher in Canada is that postal codes tend to be much smaller in Canada compared to the U.S. The U.S. zip codes have a bigger population. Postal codes are smaller. So that's why when you call your telephone company, they ask for date of birth and postal code, because this is essentially a unique identifier for you. They need nothing else to know who you are in their database. But also this means that if you have a database that contains date of birth and postal code, and I know the date of birth and postal code of my neighbor, if I find a match, there's a good chance that it's my neighbor, right? Just because such a large percentage of the population is unique on those two variables. If you reduce the precision of the information to month and year, again, if you have the full character postal code, 93% of the population is unique. But month and year, and let's say 3-character postal code, only about 2.7% of the population is unique. So by being able to measure uniqueness, you can start managing the risk by reducing the precision of the variables and reducing that identifiability. You can reduce the precision of your postal code, the precision of the geographic information, but you can also reduce the precision of the date of birth information or age information, or you can remove the gender. Removing gender doesn't have a big impact. It's mainly dates and postal codes and location information. And of course, if you do this longitudinally, So let's say over 5 years, if you have data on people where people lived over 5 years, the pattern of movement is also unique. So in this case, we had postal codes for where people lived every year for 5 years, and by looking at those patterns of movements, even if you have 3-character postal code and month and year of birth, still about 36% of the population is unique on that combination. So uniqueness is problematic because it makes people very easy to re-identify in data sets, and some very basic demographics can make individuals unique, but if you can measure it, then you can reduce that value by reducing the precision of the variables or removing certain variables from your data set. So I'll leave it at that. I guess we don't have any time for questions, but